Evet. Ben teşekkür ederim benden önceki konuşmacılara. Bu dirençli
Thank you very much to all the previous speakers. This treatment-resistant schizophrenia is an important issue, and as it seems today, treatment-resistant schizophrenia has only one solution, that is clozapine. I think it is the 63rd year when clozapine, it's the 63rd anniversary of clozapine, when it was discovered. It was 63 years ago, but still there are unmet needs in schizophrenia. And there are certain problems with regards to the antipsychotic treatment. One is efficacy. So in order to overcome this issue, we have to resort to polypharmacy. And sometimes polypharmacy can be irrational. Of course, compliance to treatment is very important. If a patient is not compliant to the treatment, then there are problems. Again, although Köksal talked about certain drugs, there is not a drug which is completely efficacious on the negative symptoms of schizophrenia. Sacrozine is at the moment studied, and there were certain disappointments. The last problem is side effects. In the first generation, there were certain Parkinson-like side effects, and then we have metabolic side effects at the moment in this second generation. This is a question we have in clozapine. Is it gold standard? Evidence-based medicine is here very important, and we have to base our judgments on evidences. Three components make up evidence-based medicine. One is the opinions of the clinicians. The other is the scientific data, and the other is a patient's acceptance and his or her adherence. This is the evidence pyramid, and the strongest one is guidelines, the other is meta-analysis, and then randomized controlled trials, epidemiological studies, and then case control studies, and case narratives and animal experiments. Let's start with the lowest level of this pyramid, that is the fourth row. Clinical trials, randomized controlled trials. Let me give you one example to this. This is Edget and Friends. The first first episode psychosis, number of patients 244. It's not a treatment-resistant schizophrenia. Risperidone and olanzapine. The first try is risperidone and olanzapine for 3 months. It was administered. They were administered with incremental doses, and 25% of the patients did not respond. The second try was they gave risperidone to the previous olanzapine group, and they did the vice versa, and 17% additional 10 patients responded. The third try was that both olanzapine and both risperidone in non-responsive patients were given clozapine, and they were able to receive 75% more response. So why don't we use clozapine at an earlier stage in the treatment? This was the question, and some practices also confirmed this. So based on evidence-based medicine, as also illustrated by the randomized controlled trials, Meltzer is an expert in this issue, and he was also a guest lecturer in our third Congress in 2009, and he also made certain presentations. He's a valuable person in this field. I think he has approximately 1,000 publishings on this issue. up until 1988, clozapine was not used. These were the periods where clozapine was not used. And up until 1996, it was found that 67,000 cases treated with clozapine suggest that clozapine does prevent suicides. Again, clozapine has this impact, anti-suicidal impact, and this is the Intercept study. For 2 years, they were given olanzapine and clozapine, 980 patients, and the clozapine group had less rates of suicide. It was a significantly important difference. In the olanzapine group, there was more weight gain, and there was another study that also confirmed this result. This is another study from Finland, between 1996 and 2006. Again, the use of clozapine decreased the suicides, and the general mortality also decreased in this clozapine using group. This is another randomized controlled trial. Clozapine also prevents relapses. In between 1995 to 2001 in Finland, it was done on a cohort there in Finland, and clozapine group was the group that discontinued the less the treatment, and they had the lowest relapse or recurrence rate, and approximately the relapse rate has been decreased up to 90%. This was another study that showed that. So yes, they prevent relapses. Clozapine use prevents relapses, and it improves life quality. Life quality is an important criterion. There is this very famous SOHO study on 9,340 patients. Olanzapine and clozapine effects were observed. In terms of clozapine has clinically superiority when compared to olanzapine. This is a multi-centered RCT. It's a CATI study, it is called. It's a very important study. Here we see that clozapine is the drug which is discontinued due to any cause. So nobody discontinues actually this drug. This is a very strong evidence. This is a meta-analysis, a Lucht's study. Lucht has many studies, meta-analysis. In 2013, he published this in Lancet and compared 15 antipsychotic drugs. More than 43,000 people were in this study, and here you can see approximately 15 antipsychotics. And clozapine is superior when compared to other antipsychotics in terms of improving all symptoms. Again, it doesn't form an EPS. In terms of sedation, clozapine is if you want sedation, it's the best you can have. In terms of weight gain, this is interesting. When compared to olanzapine, the weight gain in clozapine is lower, is lesser. Of course, treatment guidelines is the most strongest, is the most robust evidence. APA, TMAP, and PORT. They are suggesting clozapine as a third choice. You try second and third generation antipsychotic, and then for the third choice you go for clozapine, and if there is a treatment resistant schizophrenia, augmentation therapies are taking place. Again, David Osser and his colleagues worked on this Harvard algorithm project. In 2013 they modified this, and here the first line of treatment recommendation is amisulpride, aripiprazole, risperidone or ziprasidone for 4 to 6 weeks. So quetiapine, olanzapine, they are not here. Why? Because they have very important metabolic side effects. If the patient is not responding responding this, then risperidone, olanzapine can be replacing these. And the third is clozapine, as you can see. And if there is no response to this, we do it in our hospital as well. You have to check the plasma levels. I mean, you have to see if the patient is really taking their pills. And the plasma level may be very low in those smoking patients, or maybe the patient might metabolizing it very fastly. And then some augmentation treatment can also be thought.
Selçuk Kırlı, Ali Doruk, Alptekin Özşahin, Professor and Uzun also mentioned this phenomena, and there was an editorial published in our own journal based on this issue as well. Let me ask you, how many patients you administered clozapine last month? Let's raise hands. Not bad. For a year, on how many patients you use clozapine? It's not that bad. When we look at the IMS reports, between 2013 and 2014, the average use of clozapine was 2.3% amongst all other antipsychotics. Resistance amongst the schizophrenic patients was 30 to 40%, and in some residual cases, the percentage was even higher. So, I think we are using clozapine 15 times less than needed, and we are always opting for polypharmacy. It's not peculiar to our practice, to our country. This is research done in New York, and only 144 physicians preferred clozapine amongst almost 7,000 physicians. So there is clozapine phobia around the world. Clozaphobia. This is a new word, and I googled it. As Serdar said, he said, I googled it. There is no word like that. We are engaged in schizophrenia, so maybe we are trying to make an analogy between. So yes, I think there is such a fear, there is such a phobia. In some European countries, especially in China, it is 10% the use of clozapine, and in the rest of the world it's really, really less. There are unrealistic phobia vis-a-vis clozapine, and the concern is not necessary. And some young colleagues might be lacking experience. And of course, you have to have a very meticulous follow-up for the patient. You have to see the patients weekly. This was our editorial in our journal. This is the hypothesis for clozaphobia. 0.7% is the agranulocytosis risk. I don't want to go into the details of that. And the mortality risk is 0.1%. So approximately on 100,000 patients, they carried out this study in US, and it was found that 0.38% developed agranulocytosis. That is in the second 6 months of the treatment, only 0.7% developed the condition. In this study of Tionen, clozapine actually helped preventing all-cause death, all-cause mortality, and suicides. So, we are
are kind of choosing in this 10% of suicide or mortality, actually mortality due to suicide in schizophrenic patients, but you are fearing or you're getting afraid from this 0.1% of mortality due to aganoglycosis. So I think it's already something proven, that the choice that you have to make is already proven. So thanks to clozapine, we can prevent this rate of suicide that is 10%. But you still have a risk, but this risk is less than 10%, that is 0.1%, this risk of aganoglycosis. And granulocytosis colony stimulating factor can also prevent this risk of aganoglycosis. I happened to experience this, and then hematology checked my patient, and the patient is still alive thanks to this stimulating factor we administered. So we use clozapine 15 times less, and then we opt for polypharmacy. We add on things, we delete things, and then unfortunately this polypharmacy creates a lot of problems, and in many studies it was suggested that polypharmacy bring along both side effects and additional costs. Polypharmacy is opted all around the world, approximately 70-60%. The same applies for Turkey as well. This was also an editorial in our journal. From Bakırköy Hospital to many other hospitals, especially in the closed wards, we can see that polypharmacy is up to 45-60%, the prevalence of polypharmacy. Clozapine monotherapy, if administered with sufficient dose and sufficient duration, it is much more efficacious and cheaper than polypharmacy. When we also calculate all the treatments around the world, since it prevents suicide, since it prevents relapses, it's a very important agent. Irrational polypharmacy is very dangerous, and it creates important problems. So in conclusion, we can say that at least 1/3 of the schizophrenic patients are resistant to all antipsychotics except clozapine. So this is a reality. Positive symptoms, negative, slightly negative symptoms, and since it also is superior to other drugs in terms of prevention of suicide and relapse, it also improves social functions, cognitive functions, and it also is superior in terms of life quality. So that is why we have to use clozapine much more in our psychiatric practices. I wish that this will be true. This is going to be a part of our daily routine. The next Congress will be again organized here in Antalya on April